My name is Asna Yobov. I'm a current fourth-year medical student from NICOM. I'm applying to OBGYN residency this upcoming fall. Very excited, in a month from now. Very excited. But I'm very excited to moderate this talk this evening, and it is my pleasure to introduce Dr. Alexandra Dubinskaya. Dr. Alexandra is the founding physician at the Los Angeles Institute for Pelvic and Sexual Health in Beverly Hills, California. She has sculpted a multidisciplinary haven that stands as a testament to her visionary approach to women's sexual health and wellness. She blends her vast experience in urogynecology, female pelvic medicine, reconstructive surgery, sexual health, and menopause to offer a holistic care paradigm that truly celebrates and nurtures women. Her journey started in Russia, where she had the honor of training at the prestigious Northwestern State Medical University and Research Institute of Emergency Care in St. Petersburg, Russia. She then continued to the revered hallways of institutes like Tufts Medical Center in Boston and St. Francis Hospital in Hartford. She has honed her craft, always driven by her unwavering commitment to women's health. Her pivotal experience at Cedars-Sinai Medical Center in Beverly Hills, California, and as a fellow of female pelvic medicine and reconstructive surgery, further solidified her position as a vanguard in her field. It is with great pleasure that I give the floor now to Dr. Dubinskaya to speak to us.
Thank you so much, Asna, for the introduction. It's my pleasure to be here today and to talk about menopause, because there are so many things that we don't know, didn't learn about. So let's start. And if you guys have any questions, please feel free to ask after the presentation. Well, let's talk about what we learned about menopause. And as you might heard from the introduction, I actually did my training, medical training in Russia. And after finishing medical school, becoming a certified general surgeon, I actually never heard about hormone replacement therapy or menopause or what to do when you stop having kids. Some older providers would prescribe these medications, but it's never clicked in my head that, oh, there is something happening after we stop having kids. So when I moved to the United States and I was doing my training here, I noticed that there is also not so much information about menopause. In OBGYN residency, I was hoping we're going to focus on all the aspects of women's life, and that includes the time when we complete our childbearing age, and we're supposed to enjoy our life because we don't have a lot of responsibilities. We're very mature. We know what we want, and that was not the case either. So I had to learn about menopause on my own when I was in OBGYN residency. I developed this passion for pelvic floor disorders, and I wanted to help women at the times when they don't seem to have much help. So I went into urogynecology and completed fellowship. And during fellowship, that was the most I actually was learning about menopause, because majority of women who suffer with pelvic floor condition also was in perimenopause or menopause, and they had those issues, and I had to correct those issues as well, because just fixing the bladder prolapse or the incontinence didn't do much for them. And taking care of menopause is very, very important. And I'm sure that my experiences is very common and relatable for other people in medicine. So let's start with basics. Let's talk about different stages of our life. So when we are born, the level of our hormones is quite low, comparable to postmenopausal ranges. And that's actually one of the reasons why, for example, pathology like lichen sclerosis is very common in women in postmenopause and prepubertal girls. So at birth, we have a certain amount of eggs, like 1-2 millions. Our hormones are quite low. And as we go through puberty, we start growing eggs, we start ovulating. So our hormones go all over the place. And during the time, it's still our body trying to regulate, trying to figure out the right way of doing it. And then we enter into our childbearing age, where for majority of women, they have a period every month, they ovulate, they either get pregnant or develop menses, but the levels overall predictable. So then about 5 to 10 years before we actually stop having periods, we start noticing subtle changes. Some women might experience the cycles getting longer or shorter. The period can get heavier or lighter. Some might experience some new onset anxiety or depression, some rare hot flushes, some vaginal dryness, and a lot of these non-specific symptoms. Majority of women can't find the answer. They see a lot of doctors. Nobody can tell them what's exactly going on. And that can last about 5 to 10 years. So menopause, it's literally the point in life when for the past 12 months, you didn't have any period. So on that day in time, you're officially menopausal. The next day, you are postmenopausal. And the rest of your life, you will spend in postmenopause. And this is a very important concept, because when we speak to our patients and you ask them like, oh, when did you go through menopause? Or when did you stop having periods? The usual answer is, oh, I didn't go through that. I had a hot flash a couple of times and it was it. I'm over it. I'm not in menopause anymore. So it's very important for us to understand, so we can educate our patient that there is no going back. Once we stop having periods, we're in postmenopause and we will be there. And again, to talk about hormonal levels, it's quite interesting that those changes happens not at the point when we stop having periods. The changes start happening long before. If you look at this graph, you can see that from our mid-30s, we start losing our testosterone. Our progesterone progressively declining and our estrogen is going down, and after menopause goes to very low numbers. But is it only about the symptoms of like hot flash, night sweats, feeling a little uncomfortable? Not really, but those symptoms are the most commonly talked about and most commonly associated with menopause. But it's not only hot flashes. And let's just name a few. As women start going through perimenopause, the studies have shown that the levels of anxiety and depression and irritability that women develop are skyrocketing, and the need for taking antidepressants, antioxidants rises. And what's interesting, when we give those women hormones, give back what's been missing, the need for the antidepressants, anxiolytics significantly decreases. A lot of women experiencing brain fog, forgetting the words, can't recall the names. And it's all happening because our brain is filled with estrogen and testosterone receptors. So when we don't have enough of those hormones, it's very difficult for our brain to function properly. Same goes to the fatigue, headaches, migraines. Again, hot flashes and palpitations and night sweats, we all know about that. Bone health. As estrogen level declines, our bones become more fragile, and osteoporosis is extremely common. And we do DEXA scan at age of 65, but sometimes it can be a little bit too late to address the osteoporosis. So actually, hormone replacement therapy is one of the best preventative modalities to prevent bone loss, to prevent bone fracture. Because women who fall and break the hip, they have about 30% risk of death in that first year of their fracture. So it's very important to prevent osteoporosis. Significant increase of risk of cardiovascular disease. Reason women live longer than men is because we have a protective effect of estrogen. So when we stop having periods and our estrogen level declines, we become very vulnerable to developing atherosclerosis. And the theory is that declining of estrogen is happening over the course of 10 years. So if you start hormone replacement therapy within the 10 years of stopping your period, the estrogen will do you more good. And if you start estrogen after that 10-year window, the benefits is not as prominent. There are a lot of changes happening to hair, to nails. We lose our muscle mass. And there is this inability of losing weight, especially the weight that accumulates in a midsection on our stomach. One of the very common complaints is joint pain. There is actually a recent study came out about musculoskeletal syndrome of menopause, where a lot of women develop frozen shoulder, some joints pain. And the moment they start hormone replacement therapy, all the pains go away. There is a lot of changes in sexual function. Sex might become painful, some vaginal dryness, and that will cause frequent urinary tract infections, urinary and fecal incontinence, and also sleep disturbances. So it's not only hot flashes. When we stop having periods, and even when we stop having hot flashes, the changes continue to happen that deteriorates our health. And that's very important to understand and communicate to our patients. So some of the common conditions that I deal every day in my practice are pelvic floor conditions, bladder control. One of the common issues that's experienced by women is stress urinary incontinence. What it means is leakage of urine with physical activity. The reason it happens is because in our pelvic floor, we have muscles, ligaments, and they support our organs. They support bladder, vagina, bowel. So whenever muscles and ligaments are not functioning properly, it affects the function of the organs they support. So the common scenario is women have a vaginal delivery, they develop some stress urinary incontinence, it gets better with time, and then suddenly as they go through perimenopause, postmenopause, they can go for a walk, they can jog, they can't do anything because urine keep coming out. Well, the problem is that those pelvic floor muscles has a tremendous amount of estrogen receptors. And as the hormones decline, muscle become weaker and ligament gets weaker. So the stress urinary incontinence can get more prominent. Another common condition is overreactive bladder. What happens during this condition is bladder muscles keep contracting uncontrollably, and our brain perceives that as the urge to go. So overactive bladder is the people who always have to look for the bathroom, always in the bathroom, and sometimes the urge can get so strong that the urine just comes out. You can have overactive bladder at any time in your life, but it's more common in postmenopausal women. And it also happens because bladder have abundant amount of estrogen receptors. And when we're losing estrogen, the bladder muscles keep contracting uncontrollably. Pelvic organ prolapse. When pelvic organs shift from their normal position and start herniating through the vagina. And there could be different organs, bladder, bowel, uterus, or top of the vagina. There are multiple risk factors, non-modifiable, like genetic conditions, connective tissue disorders, vaginal birth, or modifiable conditions, like weight gain, weight loss. And again, because pelvic floor muscles support all these organs, pelvic organ prolapse can tend to get worse as women progress in menopause. And I can't tell you how often I hear a story of women having unmedicated birth 3 times at home, everything going so well, didn't have any issues. And now she's 62 and she's having bulge and urinary incontinence. So it's very common, and it's also very important to assess for these conditions. Our sexual health gets affected tremendously. Our desire, or we can call it libido, gets affected. And I would like to know that there are 2 types of desire. One is spontaneous, most common among men, and responsive desire, more common among women. And the good explanation of one versus another is, imagine if you want to have an ice cream. So you really want to have an ice cream, you get up, you get dressed, you drive to the ice cream store, you get your ice cream, you're happy. And responsive desire is when you don't really want ice cream, but your friend took you on a walk and you're walking by the ice cream store. You start seeing people eating ice cream. You feel the smell of this just recently baked waffle cones, and you really want to have that ice cream, and you have an ice cream. So in both case scenario, people are happy. It's very common and normal for women to not have a spontaneous desire. But as menopause progresses and the hormones changing, women stop having any sort of desire. On top of it, because pain with sex becomes more and more common, you don't really want to engage in something that causes you pain. The arousal is also being affected, and arousal is our body response to our desire. And there is a systemic arousal where all the organs and system participating in it. So increase in heart rate, increased frequency of our breath, temperature. So a lot of chronic medical conditions affect our ability to experience arousal. And during menopause, those chronic medical conditions tend to get worse. Systemic arousal is ability of our vagina to produce the lubrication. And lubrication is not only secretion of like Bartholin glands. Lubrication in part is the fluid that penetrates through the vaginal wall from those blood vessels that brought a lot of blood towards vagina. So when our vaginal walls are not able to function properly, when the lining gets thin, it's actually not only affecting our ability to lubricate, it also changes the microbiome that we have in the vagina. And changes in that microbiome also affects the pH of our vagina, and that in turn affects our ability to prevent urinary tract infection. That's why women in menopause tend to have more frequent urinary tract infections. Our ability to have an orgasm is also tend to impair as we progress in postmenopausal. We experience decreased sensation. Orgasm might be difficult to achieve, or quality of orgasm can decrease. So, but what can we do when we go through perimenopause, postmenopause? There are different components that are very important. Diet. I can't emphasize enough how important to have a healthy diet. I always recommend to my patient to have a Mediterranean style diet. Have enough protein, fiber, and vitamins. Exercise is important. And we need to start exercising early in our life. because the healthier we are when we get to perimenopausal, menopausal, the easier it will be to go through those changes. There are some non-hormonal medications. They are available, and some women prefer to take a non-hormonal medication. I always emphasize that non-hormonal medication, they treating the symptoms, they do not address the cause. It's similar how if you have a diabetes, and instead of giving you insulin, I will be giving you vitamin C. It's great to have a vitamin C, but it's not going to increase ability of your body to produce insulin. Or another example is thyroid. If you have a low thyroid function, I can give you all the behavior therapy, all the yoga in the world, but it's not going to increase the amount of thyroid hormone that you have. And the actual treatment option for menopause is hormone replacement therapy. And I would like to focus on it a little bit more. So what are we replacing? We're replacing what we're losing, estrogen. And there are two types of hormone replacement: systemic hormone replacement and local. So systemic hormone replacement works on the whole body. So when you use the systemic hormones, it prevents osteoporosis, improves cholesterol, improves and removes hot flashes, helps to maintain weight, provide better sleep, and actually decrease risk of dementia. The systemic therapy administered into different options. Pills, which we don't really give pills anymore, because we know that if we administer estrogen orally, it metabolizes through the liver, and it actually increases the amount of synthesized clotting factors. So it will increase the risk of thrombosis, and it actually increases the amount of bad cholesterol. So pills are not the good option. There are patches, and they are usually covered by insurance, available through the pharmacy, and you can change them twice a week or once a week. Twice a week patches, they tend to be smaller and stay longer. And their once a week patches, they tend to come off very easily. So during the summer, or if a woman is very active, likes to swim, go to the gym, those once a week patches will likely won't stay as long as they need to. Gels like estrogel is a great option. The only issue is majority of insurance do not like to cover the estrogen gel, or at least that's what I'm noticing here in California. But again, great for very physically active women. Injections are not commonly used and only used for women who are very fast, like metabolizing estrogen very fast. But again, it's not as common modality. And pellets. You probably heard a lot of controversy around pellets. I think the controversy happening because we don't have enough data and we don't have FDA approval. And there are people who swears by them, and there are people who don't like them. In my practice, I usually discuss with the patients what would work best for their lifestyle. Some women like to have this everyday routine when they're applying their patch or they're applying their gel, take their pills. And some women just can't remember taking pills or applying anything on their body. So getting pellets once every 3-4 months is the best option for them. So local hormone replacement therapy. When we talk about local, we talk about the vaginal hormone replacement therapy. And it helps with vaginal health. It's rebuild the vaginal lining. It helps with bladder health. Actually, 50% of women who have overreactive bladder will improve with use of vaginal estrogen. It's a pretty significant number. It also helps with vaginal lubrication and helps improve quality of sex. Um, the vaginal estrogen can come in different forms as well. Vaginal cream, you probably heard about Premarin, estrace. They both are great. Premarin has tendency to burn a little more. So when I have opportunity, I usually stick with estrace. There is little capsules, like for example, called Imvexi, very comfortable to use, but sometimes can be difficult to get approval from the insurance. There is inserts that look like a little small Tic Tacs that you just insert twice a week. Or ring. Some women who are older have hand arthritis or any issues with dexterity or memory. Ring can be an amazing option because it's a very soft, small ring that goes in the vagina, stays there for 3 months, produces estrogen, and then in 3 months, women come back to the doctor, we remove the ring and place a new one. So it's a really, really good option for those women who has a frequent urinary tract infection or even in nursing facilities. This is actually can save lives. Then we replacing progesterone, and progesterone, the main reason to give progesterone is to counteract the effect of estrogen on the uterus, so prevent women from having bleeding and from developing uterine cancer from unopposed estrogen. It also comes with a side effect of improved sleep, and it also improves hot flashes as well. So traditional way of giving back progesterone is the pill. Some women have to use a cream, and it's usually in a situation where somebody is allergic to peanuts, because in the pill there is a peanut component, and when you make a cream in the compounding pharmacy, they can remove that component and add something else. Alternative for progesterone replacement is IUD. So any hormone-containing IUD would work. It's not a conventional way of protecting endometrial lining, but hey, IUD has been used as an option for treating early stages of uterine cancer. I'm sure it would work just fine to protect the endometrial lining when you give a very small dose of estrogens. And testosterone. Well, historically, testosterone been considered to be as a male hormone, and like only men has testosterone and women have estrogen. But it's actually not true. We have more testosterone than we have estrogen, and testosterone has a lot of benefits and protective effect on multiple organs and system. And we still like more and more studies coming up discovering how good testosterone for us. Testosterone prevents osteoporosis. It participates in improving cholesterol and lipids, protects our heart, improves conditions. It also increased our energy, helps with sexual health, also helps with preventing dementia, and decreased risk of breast cancer. There is actually a study that's shown that testosterone reminds the cells to stop dividing, to basically die. So it promotes apoptosis. By doing that, it actually prevents the breast cancer. So testosterone can be replaced in 3 different ways. We don't have an FDA-approved form of female testosterone. So our option are using a testosterone gel that was made for men and redosing it for women. The downside of doing that, it requires a very interested patient who will continue to measure and do a correct dosing. And sometimes that can be an issue. There is also Androfem, the Australian-made testosterone specifically for women. And anyone with a MD license in the United States, MD-ODO, can order the Androfem from Australia. It does take a couple of weeks to receive the gel, but it's totally doable. It comes with a syringe and it's very easy to dose. The only negative feedback that I have received about Androfem is that it's a little bit sticky structure, and it can be a little bit annoying for some patients. And another alternative option is to go with compounding pharmacy and make a testosterone cream. It's not the best option, not what's recommended, but if there is no other option, that's the only thing that we can do that's totally appropriate to do. And they would apply that cream on a thigh every morning. And there are a lot of common myths about testosterone, that it will cause the hair loss. Well, you would have to use it in significant doses in order for that to happen. Some women ask me if it would change their voice. And again, you do need to use a lot in order for it to happen. Or will it enlarge my clitoris? And I like to remind them that the people who go through like gender treatment, gender transition, they use a large doses on a regular basis over the course of years to get those changes. And the doses that we give as a testosterone replacement, physiologic testosterone replacement, is significantly lower. So that's all myth. So when is the right time to start hormone replacement therapy? Anytime woman is symptomatic, it's appropriate time to start. Do we need to wait until we stop having periods? No, we don't, because again, it's mostly in theory, when you're 12 months, you're periods free, you're in menopause. But if you're feeling horrible before that, there is absolutely no reason to wait until you finish your periods. And there is an ideal time to start hormone replacement therapy. And it's considered to be within 10 years of stopping having periods. And again, that's mostly because we believe that that's the time when we still have some protective effect from our natural estrogens. And then introducing hormone replacement therapy after that golden window can pose some risk, but it's not a contraindication, and it mostly involves discussion between provider and a patient. So some women will ask me, do I need to stop the hormone replacement therapy? I usually tell them that whenever you're ready to feel miserable and die from chronic diseases, then that's when you should stop your hormone replacement therapy. And the common question that I'm sure all of us got at some point is, will estrogen give me cancer? And the reason why women ask this question is because there was a study done, you probably heard about that study, WHI, Women's Health Initiative. The study was created to evaluate the effect of hormone replacement therapy on cardiovascular disease, thrombosis, and breast cancer. So they have the group of women who was taking only oral estrogen. They didn't have a uterus. Women who took oral estrogen and synthetic progestins, they did have a uterus, and the women who didn't take anything. So the important things to notice is in that study, majority of women who were enrolled were 62 years and older, which is again kind of pushing it towards the end of that golden window, 10 years. The estrogen that they took was oral estrogen. And again, we remember that oral estrogen metabolizes through the liver and increase the risk of blood clots, increased risk of the bad cholesterol. And they also took synthetic progestins, which till this day, there is some study that showed that it can be actually a culprit of developing breast cancer. So the study, bottom line study, was not done completely was not organized well, and they start noticing that women develop breast cancer even though nobody was screened for breast cancer, and a regional recruitment started developing blood clots, so the study was stopped before even they had a chance to go back and review the data. It leaked into the press, and it created this amazing headlines of HRT linked to breast cancer, HRT kills, and overnight, thousands, if not millions of women were taking off hormone replacement therapy. And since that day, hormones got this like bad rap. Whenever you say estrogen, people automatically think cancer. Even though we live majority of our life with tons of estrogen on board. When we're pregnant, we have highest amount of estrogen. But moment we stop having our natural estrogen, that's when the women start worrying about breast cancer due to replacement. So when some other studies went back and looked at the data of WHI study, and they actually specifically took only and evaluated only the women between age of 50 and 59. And they the upper graph, it shows only women on oral estrogen, and the bottom graph is oral estrogen and progestins. And they looked at all risks. So everything yellow is risk increased, everything blue is risk decreased. Again, remember, it's oral estrogen. So yes, we will see the increase of stroke. We can see the risk of increase of pulmonary embolism. But look over here, all cancer deaths are decreased. All cancer deaths are decreased. And in breast cancer is also decreased in only estrogen trial. It's in the estrogen and progestin, we see increase of risk of breast cancer. But again, it's probably due to the progestins on board and not due to the estrogens. There is amazing oncologist and writer, Avrum Bluming. He wrote a book, Estrogen Matters, and he also did a lot of research on the breast cancer and HRT, partially because his own wife actually had a breast cancer and had terrible menopausal symptoms. So he reviewed multiple studies and actually found only one study that showed increased risk of recurrence of breast cancer, but that recurrence was very limited to local or contralateral sites and not distant and recurrent. And actually women who were on hormone replacement therapy, who developed breast cancer during the hormone replacement therapy, they had a better outcome. And it's very important to remember that women who had a breast cancer, they have a higher chances of dying of cardiovascular disease than dying from the breast cancer. So starting hormone replacement therapy in someone who had a personal history of breast cancer requires a long conversation and weighing in risks and benefits. And remember, high doses of estrogen used to be the main treatment option for the breast cancer in the past. So what are the actual contraindications for hormone replacement therapy? There are absolute contraindications, for example, active vaginal bleeding of a known etiology. So what it means that you should evaluate the bleeding first and the reason why it's happening before prescribing HRT. And if somebody is in active treatment for breast cancer, you should not give them treatment at that time. Relative contraindications are history of thrombosis. Very important to evaluate when it happened, how it happened. And remember, transdermal estrogen does not increase the risk of thrombosis, does not increase clotting factors. And personal history of breast cancer, again, requires individual conversation. So how to find help and how to find the providers. So one of the great resources is the Menopause Society. you as a provider can find a lot of answers, ask questions, and there is actually a list of Menopause Society certified providers, which can be helpful for patients to look and find the people who can help them treat their menopausal symptoms. International Society for Sexual Medicine and International Society for the Study of Women's Sexual Health, even though they're mostly about sexual health, there are a lot of information that can be helpful when you treat women in postmenopause, and a lot of review also of the hormone therapies. And again, please, 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 if you haven't read yet, read the book by Avram Blooming, Estrogen Matters. You won't regret it. It's a really good resource. With that, thank you so much for listening. I hope it helped in your practice for your patients, and I'm happy to take any questions.
Thank you so much, Dr. Dubinskaya, for that amazing presentation. We have a couple of questions that I'm going to ask here, and to our audience, please feel free to listen in on these questions, and you have the option to anonymously submit a question in the Q&A box. So one of the first questions we have is, for women who have many vaginal births, is there anything we can do to strengthen our pelvic floor before it's too late? Any way to prevent pelvic organ prolapse in menopause for those of us who have many children?
Yeah, it's a great question. Well, for the pelvic organ prolapse, there are some factors that we can modify. So if your mom, your grandmother had a prolapse, you have a predisposing risk of developing prolapse. Or let's say if you have connective tissue disorder, like you have Ehlers-Danlos, or you're very flexible to begin with, you probably will develop prolapse at some point. Some chronic conditions, for example, chronic cough, or anything that increase the abdominal pressure, for example, like chronic constipation, when women spend a long time on the toilet pushing. If you control those conditions and decrease the amount when your abdominal pressure is elevated, that will help. Vaginal birth, considered to be modifiable factor, but I don't think it's really modifiable. Like I'm as a urogynecologist, I did have elective C-section because of that, and a lot of my colleagues did too. But I don't think that majority of women can actually pick and choose. Unfortunately, I would say make sure that you maintain healthy weight, maintain a healthy diet, prevent constipation. And if you sit on a toilet and you can't have a bowel movement, get up and go, come back later. Do not spend a long time on a toilet. And also, right after delivery, let your pelvic floor rest. Do not go and start lifting heavy thing. Let your pelvic floor to recover. And if you can, go to pelvic floor to physical therapy. That would be great.
And to follow up with that, is doing Kegel exercises helpful?
Yeah, so anytime I say pelvic floor, usually people think Kegels, because again, Kegels has a great PR in this way. Well, this is the thing, that Kegels usually recommended when you have, let's say, urinary leakage. But the issue is that you might have urinary leakage not because your pelvic floor is weak, but also because your pelvic floor muscles are very contracted. So they're not at optimal length and they can't perform the activity, like duties that they need to perform at the optimal level. So before going ahead and doing tons of Kegels, I would recommend to see pelvic floor physical therapist or urogynecologist who can evaluate your pelvic floor and tell you, like, you know what, you do have a weak pelvic floor, Kegels will be beneficial. Or, you know, you need to learn how to relax those muscles, and they can actually teach you how to do it.
Thank you. Another question that we have is, can you please describe what a hot flash is? Can it be just feeling very hot with or without sweating? Does it make you feel off?
Okay, full disclosure, I haven't had my hot flash yet, but based on what my patient described to me or my relative described to me, it is overwhelming feeling of like heat that comes along with some like anxiety feeling, and some people might break into sweats, and some people might not have a sweats right away. And it's all depends on how people experience the sweating and perceive the heat. So I guess that's the best how I can explain that.
Thank you. Another question that we have is, which lubricants do you recommend for vaginal dryness? Water-based, oil-based, any natural?
Yeah. So again, other than doing vaginal estrogen that's improve your own lubrication, it's very normal to use a lubricants, and even younger women in their 20s, they use lubricant. It's totally normal. And interestingly enough, there was a study done that evaluated sexual activity with and without lubricants, and using lubricant showed improved satisfaction and sexual pleasure. So using lubricant is good. Depending on personal preferences, the silicone-based lubricant would last longer. You don't have to reapply it, and you can actually use it like in a water shower, bathtub, whatever you do. Water-based lubricant requires multiple applications. So every couple of minutes, you need to reapply it because it will get absorbed. And in postmenopausal women, when you use the water-based lubricant, what tend to happen, the tissue starts absorbing, and it's kind of like drying out the tissue and can actually irritate the vaginal tissue in perimenopausal, menopausal women. The oil-based lubricants sometimes can cause some irritation, and it can damage the sheets or whatever is around. So I think my personal recommendation would be a silicone-based lubricant.
Thank you. And our last question for the night. For teachers, nurses, or just moms who don't have time to go to the bathroom, is it true that holding in urine is unhealthy, or is that just an old wives' tale?
You know, it depends. I don't think it's completely like old wives' tales, and it's not completely dangerous for you. We do like, it's totally known that teachers, mothers, doctors, we all hold it longer. And it's also important to what degree. If that's the only thing that we do with our pelvic floor, okay, that's fine. But if it comes with our pelvic floor constantly being contracted, if you also, in addition to it, noticing that bowel movements are painful, sex is painful, you might be suffering with pelvic floor dysfunction. And in that case, you do need to learn how to relax your pelvic floor. So it depends.
Thank you so much for that. And on that note, thank you everyone for attending and joining this webinar. This was extremely educational. Thank you so much to Dr. Dubinskaya for taking time out of your schedule to come speak to us. Thank you to the Women's Health Committee and everyone who organized this event. And thank you most importantly to our attendees.
Yeah,
And
thank you so much. It was my pleasure.
thank you. And God willing, we'll have many more of these types of events. Dr. Dubinskaya, if you could stop sharing your screen, I would like to take a picture of our panelists so we have this for memory. And then everyone, I hope you have a great night. For my committee members, please let me know if you're able to turn on your cameras. If not, it's okay. Hello. All right, everybody else, smile. Perfect. Thank you so much, everyone. Have a fantastic rest of your day or night. Bye.
Bye.